Hello, welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds series. And my name is Joe Saramelli, and I oversee Grand Rounds for our department. This is one of the final three presentations in the Grand Round series for this academic year. We've had presentations across several different domains. And I want to talk a little bit about today's format of the presentation, which is a new format. For today, write in questions or comments into the chat box or the Q&A, and I'll monitor those and can go through those with the group of presenters at the end. And I'd like to encourage you as well to fill out the post-Grand Rounds evaluation, which goes out in the Grand Rounds announcements. Today's presentation is different. We're piloting out a new format with a new series of objectives. We're so far calling this kind of the state-of-the-art format or state-of-the-art presentation. And the format, as you see, is multiple people presenting, usually from a clinical service or a team. And the focus is clinically focused presentation from a group that's providing care for a specific population. And what's the objective? Answering the question, what is the current state of clinical care here within our department or within UW Medicine? What happens when a patient presents for care? And where can care head, or where should it head? These are the types of example questions of the objective of this new type of presentation. I'm very curious about what you think about this, and if there's others who would like to take this on with their own group of a clinical service to talk about a different patient population. But for today, I'm very glad we've got a group focusing on first episode psychosis. And the presenters today include Dr. Maria Monroe DeVita, who's an associate professor in our department and co-director of what's called the Spirit Lab, the Washington State Center of Excellence in Early Psychosis, supporting psychosis innovation through research, implementation, and support. And Dr. Christine Curry, who is a clinical assistant professor, also in the STEP program. Nami Bhatt, the program director and a family education specialist in the STEP program. Dr. Lydia Trostiak, a professor, also working in the Spirit Lab and co-director of the Spirit Lab. And Dr. Sarah Kapelovich, assistant professor, also with a professorship in cognitive behavioral therapy for psychosis in the Spirit Lab. So I'll stop there and turn it over, and I'll be monitoring the chat for questions. And thank you to the group of presenters.
Thanks, Joe. Appreciate the introduction, and we're excited to lead off on this new way of doing team-based presentation, which kind of models our work that we're doing in team-based care. So let's see, I'm going to go ahead and share my screen here. Everything looking okay?
Yes.
Okay, we'll get started then. So before we kind of get started on the content today, I'd like to begin with a bit of gratitude. First and foremost, we'd really like to acknowledge our funders, as so many of them came to supporting this work because psychosis has directly impacted their own lives or the lives of their loved ones in some way. It's really hard to believe, but as recently as 5 or 6 years ago, working in this particular area was just an aspiration. It was, this little glimmer in our eyes. There was no specialized care or research, and just a little bit of workforce development happening in our department related to FEP or first episode psychosis. But thanks to the support from the Washington State Healthcare Authority, along with numerous individual and anonymous donors to the UW Medicine Behavioral Health Institute, or BHI, at Harborview, we're here today to share with all of you where some of this work stands and where we want it to go. I also wanted to acknowledge relevant funding for 2 of our presenters who, as you mentioned earlier, are endowed professors, Dr. Christine Curry and Dr. Sarah Kapelovich. These professorships and the important work that they support for these 2 faculty members continues to build our capacity for FEP care as a whole. We would also like to thank our funder and collaborator at the Washington Healthcare Authority, Becky Daughtry, Carolyn Brenner, Ali Franklin, and Mark Snowden for their support for developing and sustaining the STEP team, which we will present on today. Our chair, Dr. Jürgen Unitzer, who had the vision and prioritized early psychosis as an area of advancement within our department several years ago. Our collaborators at WSU, whose evaluation data we'll be sharing today, and our amazing research coordinator, Matthew Christensen, who supported the work of all of our team. Our group of presenters today will focus on work related to first episode psychosis at a variety of levels. Doctors Sarah Kapelovich and Lydia Schwastiak and myself represent several centers that focus on FEP and serious mental illness. That includes the Washington State Center of Excellence in Early Psychosis, which we co-established with our WSU colleagues. The Spirit Lab, as Joe mentioned, which focuses on supporting psychosis innovation through research, implementation, and training. And that work also includes the training and implementation support we provide to our state's New Journeys coordinated specialty care teams, as well as the STEP team, and the Northwest Mental Health Technology Transfer Center, MHTTC, which Lydia co-directs, and where we're all involved in training and supporting the workforce in this area at both the regional and national levels, working collaboratively with groups like the Prodrome and Early Psychosis Program Network, which is also known as PEPNET, and the MHTTC's network-wide working group on early psychosis. Nami Bhatt and Dr. Christine Curry both work then clinically within the STEP team at the BHI. As mentioned earlier, Nami is the program director and family education specialist, and Christine is the psychiatrist for the team. So I will get us started off with providing a rationale for and background on the coordinated specialty care model for FEP. Then I'll turn it over to Nami and Christine, who will share more about the clinical team at STEP and will walk us through a clinical vignette. While we're actively working on a number of clinical innovation projects related to FEP right now, given our brief time today, just an hour, we'll feature just 2 examples of that work. So Lydia will present on piloting a nurse care manager role within CSE, and Sarah will present on the CAPS program, which holds promise for extending early detection beyond first episode. Okay, so let's start with setting the stage by talking about the problem we are facing today in this area. Each year, approximately 100,000 young people experience a first episode of psychosis. Many of these individuals and families go without care for long periods of time. In the US, the average duration of untreated psychosis, or DUP as we'll continue to refer to it, is more than 2 years. That's in spite of the fact that the World Health Organization suggests that specialty care for FEP start within 3 months of illness onset. So other than the obvious, here's why that's a serious problem. Multiple individual and meta-analytic studies suggest that DUP is a strong prognostic indicator. That includes longer DUP contributes to more frequent relapse, a longer course of illness, and more profound disability. While a relatively low prevalence disorder, the burden of disease for psychosis and schizophrenia spectrum disorders in particular is substantial. Psychosis is associated with high disability, accounting for a significant proportion of Social Security expenditures with enormous personal and societal costs. People who experience psychotic disorders are also at higher risk of poor long-term health outcomes and decreased life expectancy, which Lydia is going to talk about more later. And then suicide rates are also higher, as are rates of homelessness and incarceration in this population. So yes, that's the bad news, but this is when I switch to the good news. And that good news is partially rooted in a program called Coordinated Specialty Care, or CSC. The term CSC was first coined in a seminal white paper by NIMH to describe the evidence-based model for treating FEP. It's based on models originally implemented in other countries, particularly those with some form of universal health care, including Australia, Britain, Canada, and Scandinavia. It leverages a multidisciplinary, multi-component approach to FEP treatment. Systematic reviews and meta-analyses of CSC worldwide show significantly positive outcomes in the areas you see here as compared to treatment as usual. And again, the wealth of evidence suggesting the shorter the DUP, the better the outcome, and vice versa, with poor outcomes measured up to 15 years later. So Nami is going to talk in more detail about the team roles and services provided in CSC, but here are the typical components, including low-dose select antipsychotic medications, case management, evidence-based psychotherapy, typically provided individually, but sometimes also offered in groups, supported employment and education, peer services, and family education and support, because we know that the vast majority of these folks are living at home and spending most of their time with their families. And then another significant and important feature is community outreach and education about first episode psychosis, which also serves to generate referrals to the program and potentially to other related services in the community. CSC became more commonly implemented in the US after NIMH prioritized FEP and implemented the RAISE initiative in 2009. They funded 2 research studies at the time. The first was the RAISE Connections program. Dr. Lisa Dixon was the PI of this quasi-experimental and qualitative study. Some of you may be familiar with the model CSC program that came out of that study, which is now called On Track, or On Track New York. And then the second was the RAISE Early Treatment Program, or ETP. Dr. John Kane was the PI of this RCT, and the CSC model that came out of that particular study is now referred to as Navigate. RAISE ETP remains the largest and only multi-site RCT of coordinated specialty care in the US within community behavioral health agencies, demonstrating similar positive outcomes as I described in the last slide. And then outside of RAISE, only a handful of CSC programs existed in the US, with Oregon being an early adopter with their ESA programs based on a model out of Australia. But it wasn't until 2014 when President Obama signed into law HR 3547, which provided funding to SAMHSA to support development of FEP programs, starting with a 5% set aside and mental health block grant funding to each state, which increased to 10% in 2016 and remains today. So that brings us to Washington State right here at home, where we now have 11 New Journeys coordinated specialty care teams that have been implemented since the first set aside dollars were dispersed in 2014. These programs are grounded in the Navigate model of CSC I mentioned earlier. New Journeys has demonstrated similar outcomes in an ongoing pre-post evaluation conducted by our colleagues at WSU across 325 New Journeys participants. Our WSU colleagues found that over the course of 24 months in New Journeys, individuals reported significantly fewer psychotic experiences and symptoms. You can see a similar trend here across various types of symptoms, as well as significant reductions in both depression and anxiety, which interestingly hasn't been found in other studies, but is certainly a positive finding. And then related to education and employment, enrollment in school increased from 24% at intake to 30% post-intake, which wasn't a significant difference, but still a reduction, which or increase, I should say, which I think is noteworthy. I think one possible explanation related to why this wasn't significant, maybe due to the fact that our New Journeys participants' average age is 20 years, so they may be perhaps focused more on employment than school. And then part-time employment attendance and volunteer work increased from about 8% to 20% post-intake. There was a statistically significant change in working or volunteering 20 or more hours a week from intake to post-intake, but not for those looking for work. Only the number of days worked, but not days volunteered, was found to be statistically significant. And then lastly, there was no significant decrease in participants' substance use, which highlights an important area of program development we're actually working on as we speak, and would love to come back and tell you more about that in the future. So that brings us to STEP. And while those New Journey sites were launching across the state, Harborview was actively working to develop their own CSC program with different funding through philanthropic support and billable services. So I'll turn it over to Nami and Christine to tell you more about the STEP program.
Thank you, Maria, for the introduction. So STEP stands for Specialized Treatment for Early Psychosis. You'll see our pictures of our whole team on this next slide here. We've got 7 team members currently. We do have a specific admission criteria that does follow similarly to the other first episode programs in the state. Our age range is 15 to 40, while most of our clients do fall between, I would say, 18 to 25, but we do have some outliers. Diagnostically, we focus on serving individuals on the schizophrenia spectrum. Duration of illness, really looking at that less than or equal to 2-year mark. The exclusion criteria is listed for you here as well. Most common diagnoses that we do get referrals for but don't meet the admission criteria include bipolar disorder with psychotic features, major depressive disorder with psychotic features, substance-induced psychosis, and individuals with co-occurring autism spectrum disorder. In order to help with diagnostic clarity, we do have 3 clinicians on our team that are trained in the SCIT to help determine eligibility. Overall, we get most of our referrals from inpatient teams, both inside and outside of the UW system. But that being said, we do get community and self-referrals and are always open to all. With the clients that we currently have enrolled, about 60% of them do meet criteria for schizophrenia, about 30% meet criteria for schizoaffective disorder, and then we have about 10% where we're still living in that psychosis unspecified range where we need a couple more months of treatment and assessment before knowing diagnostic clarity. So as Maria shared, the coordinated specialty care model, this is the model showing all of the different components of STEP. What sets us apart from most of the New Journeys teams is that we were the first team to roll out the nursing role, as well as having a cognitive behavioral therapy for psychosis clinician, kind of along with that IRT. I'll share more about each role over the next slides as well. In the upper right-hand corner, you do see that we in general are serving about 30 clients at each given time, and clients are typically in the program for about 2 years, but of course it's kind of never cut and dry. We do have clients that either graduate earlier or we find diagnostically maybe STEP is not the right fit, so they transition out sooner. And then we also sometimes hold on to clients a bit longer, mostly to ensure that we're providing them with a warm handoff to their next treatment provider, whether that's community mental health, private practice, or even their primary care provider. As we know, it's often hard to determine course of treatment, what it'll look like, and so we try our best to follow the model while also providing the best care for our clients. So now going into each role more specifically, most often there's one individual that is the program director and the family education specialist. The program director really is that main point of contact for anything that comes up, from crises to referrals to supervision and feedback of each role, scheduling follow-ups, anything at all. A major part of the role for program director is to provide community outreach and education, which involves going to inpatient units, family homes, schools, community centers, anywhere really, to provide education on what emerging psychosis could look like, and also to do screenings. Although COVID has unfortunately limited our ability to do much of this, we are making this aspect a priority of the role right now. The family education specialist offers family support as often as weekly or whatever looks best for the caregivers of individuals in the program. Family education is not limited to just parents or siblings. It's a space for anyone who the individual identifies as a caregiver or figure of support. And it's really a space to provide education and offer skills to best support our young individuals as they begin their recovery. We try to help caregivers support the client's goals versus focusing on their own goals. For example, the client may want to focus on their social life, where the family may want them to focus on academics. And so that family education specialist is the person to kind of help caregivers navigate those discrepancies and focus on client goals. As I mentioned, STEP does have both an IRT, so an individual resiliency trainer, as well as a psychologist offering CBTP, or cognitive behavioral therapy for psychosis. STEP has invested in offering multiple modalities of psychotherapy to really help meet the clients where they're at, and that's something that we really value. Both modalities are grounded in similar CBT foundations, but the two models do differ. In general, what we've seen is that IRT may be a better fit for clients who are curious about exploring their symptoms and are open to receiving more psychoeducation. You are using more words like hallucinations, delusions, etc. While in CBTP, the beginning sessions are focused more on befriending, normalization, and kind of gentle exploration of the experiences. So we are really trying to offer a range of support. The IRT also follows the manualized navigate treatment, while the CBTP clinician might have some more flexibility in what to address. We are lucky that we have 2 members on our medical team, both a psychiatrist and a nurse. We do like to emphasize that medication is not a required part of treatment for STEP. again, focusing on meeting our clients where they're at in this process. Our clients will still meet regularly with our medical team to talk and learn about medication. So focusing again on that psychoeducation aspect. Our goal is to always help these clients find the lowest, most therapeutic dose possible for medication. And this often does take multiple trials, which is something we find the young population really struggling with. Our nurse has been a huge, amazing role for our clients. It's allowed our clients to find a space that sometimes feel more comfortable to talk about medications and the risk factors and targets as written. So exploring the relationship between medications, physical activity, diet, sleep hygiene, sexual health, etc. We often do see our clients suffering a lot of side effects and negative outcomes of their mental health conditions, and the nursing role has been really helpful for this. And Dr. Schwastiak will share much more about the pilot and the development of this role later on. The supported employment and education specialist has been a very important part of STEP. A lot of times clients are unable to identify mental health goals, but what they can identify is a career or education goal. So we've found this role to be a nice hook for some of our clients that are maybe not so ready to talk about psychosis. This role has also helped cultivate hope for a lot of our clients. Like, they are often able to continue with work or education, even if that means just part-time or working with accommodations. So it helps to show them that their life doesn't necessarily have to completely stop or change because of their break or their onset of symptoms. We are working on having the C specialists spend more time in the community with our clients. So dropping off resumes at potential workplaces or exploring volunteer opportunities, things as such. Definitionally, a peer support specialist is an individual with their own lived experience of mental health recovery. This role, along with the C specialist, has been a vital part of our team. We do find that a lot of our clients have connected with the peer support specialist before other members of the team. And I do believe it can be and feel more comfortable talking with someone that may be able to relate better when you're just starting to navigate everything. And then lastly, we do have case management. Currently, it's mostly shared between the program director and IRT role. But that being said, all members of the team are willing to help out. We really want to help these young individuals be as independent as they can. And sometimes that can involve helping them get a reduced bus pass, set up bank accounts, pay bills, really anything that can support our clients in learning how to navigate the system on their own as their recovery does continue. Some additional information related to STEP specifically. We do offer multiple types of groups. So we have a cognitive behavioral therapy for psychosis group that's run by our CBTP clinician, a STEP social club that's run by our peer support specialist. And then in the works, we're talking about starting an active group that's run by our IRT specialist. And we offer a support group for caregivers and family members called Building Connections. So we really have seen a variety of engagement from clients and families by offering an array of groups that are run by different team members. And we plan to continue to expand and explore different group modalities as well. We are both office and outreach based, again, just depending on what makes our clients and caregivers feel most comfortable and supported. When and if a client is hospitalized, we do like to continue to maintain and support or engage with those clients while they're in the hospital. And we do try to have multiple members of the team reach out to the clients as well. STEP really does strive to focus on the client's needs. We always want to make sure we are respecting their personal values. We want to be as recovery oriented as possible while still continuing to incorporate that evidence-based treatment. Something I know each of our team members feel passionately about is that at the end of the day, it's really about the client's beliefs, values, and goals that mean the most. And, it's not always about maybe what the family members or providers want. So with that, I will pass it on to Dr. Christine Curry to share a clinical vignette.
Thanks so much, Nami, and thanks so much, Maria. So we wanted to share a vignette to tell you a little more about the program. This is a cisgender, heterosexual, mixed-race young man in his mid-20s with a history of anxiety and OCD symptoms since childhood, referred by his outpatient therapist due to 2 episodes of psychotic symptoms, presenting with an interest in preventing psychotic symptoms, finishing his education, and establishing himself with independence in Seattle. His first psychotic symptoms were in 2017 in the context of using cannabis, MDMA, and mushrooms. He was hospitalized and diagnosed with substance-induced psychosis at that time treated and responded quickly to a high dose of risperidone, which he took for 5 months, but discontinued due to significant side effects, including blunting and sedation. At that time, and he also was hoping to avoid long-term psychiatric medications as much as possible. He had recurrent psychotic symptoms in 2019. He had moved to the US to take a prep course for college. What started as kind of obsessive concerns and rituals about health and self-care worsened and progressed to the point where they were taking up a large majority of his day and making it hard to function. He actually had to move in with a family member for support. He expressed to them not feeling right and being in a spiritual war. He left on a walk one day and wasn't found for 2 days, was found by the police jumping off cars, and expressed in the ER that he was having command auditory hallucinations to harm himself in order to save others in the world from a World War III. He declined medications at the time, leading to an involuntary hospitalization, and had, again, rapid improvement on oral Haldol. Of note, he was not on any substances and had not been in the preceding months prior to this admission. He discontinued medications after discharge and presented very quickly thereafter to STEP, interested in relapse prevention, not having any psychotic symptoms, with OCD in good control and not having other mood symptoms. He very clearly expressed a strong wish to avoid medications and endorsed a lot of trauma in his previous involuntary treatment settings, as well as some trauma related to medications and side effects. He was polite but guarded about his history of psychotic symptoms on initial presentation. In terms of his history, he did have a history significant for OCD, as I mentioned. Those OCD symptoms were significant, diagnosed at age 11, and actually required travel to the US to obtain psychotherapy. He also, as a child and teen, was trying to avoid psychiatric medications as much as possible and only had brief trials of an SSRI and aripiprazole. He had been misdiagnosed with ADHD early in his childhood. He found that diagnosis to be in error, as well as expressing a lot of distress about the tics and robotic sensations he had on stimulants. In terms of substance history, he did use cannabis in his teens and began using MDMA and mushrooms in high school. Of note, as I mentioned, he'd been sober for 2 years prior to initiation or care at STEP, primarily due to a fear of relapsing or recurrent psychotic symptoms. His medical history was unremarkable. There was no significant factors on review of systems. He was not on any medications and did not have allergies. His family history was notable only for 2 uncles with substance use disorder. And his lab work and imaging during each of his admissions was was benign, and I've included some of the information from like the most recent hospitalization. And yeah, he was not interested in further workup for non-psychiatric causes of psychosis, and there were no other concerning symptoms to pursue. In terms of his social history, his family had lived internationally in a bunch of different locations, his parents working abroad in multiple locations, but he had also spent time in Seattle during childhood. As I mentioned, there was a prolonged trip to the US to get treatment for OCD. He had come back to his family really hopeful about sharing his skills and improvement with his OCD symptoms in his preteens, only to find that his parents were divorcing, which he describes feeling responsible for that breakup throughout his development. He then lived with his father and his father's new family or new wife, and describes feeling alienated and mistreated at times by members of the new family, leaving that family and actually living independently in the previous family home throughout his teens, which he describes as the hardest period, and yet was similarly guarded and a little vague about exactly what made that difficult. He did graduate from high school and worked part-time doing some volunteer work, and then a few years later was coming to the US to engage in college prep courses for business. He rented his own apartment, but lived with his family intermittently for support. And he feels well supported in general by his family and all members, and has a lifelong interest in health and fitness. A few months after engagement with STEP, a few months after doing some relapse prevention, he was hospitalized for a recurrent episode of catatonia and paranoia. Again, the progression of symptoms was rather gradual, but leading to profound symptoms, being found not eating, and an apartment in disrepair. Catatonia was observed for the first time with mutism, odd postures, and repetitive phrases. This led to a several-week involuntary hospitalization where he was treated with up to 12 milligrams of lorazepam in order to have the catatonic symptoms abate. As he came out of the catatonic state, he consistently and strongly declined antipsychotics. There was an attempt made to avoid the further trauma of antipsychotics in forced settings, an attempt to taper lorazepam, which led to recurrent psychosis and catatonia. At that point in time, in order to pursue his goals of discharge, he accepted a low dose of an antipsychotic. Thereafter, in his engagement with the STEP team, he was much more open about experiencing a systematized delusion concerning perceived ancestral transgressions and the need for him to atone through his own actions in order to save himself, his family, and the world. It was pervasive and had effects on almost every aspect of his life and his behaviors. While he endorsed auditory hallucinations when symptoms were quite severe, in general, he experienced them instead as intrusive thoughts. And themes of the psychotic symptoms included powerlessness, guilt, shame, and grandiosity. I want to talk a little bit about his engagement with each of the team members. In terms of family support, they were grateful for immediate crisis support and psychoeducation. His mother was initially the primary support during that period of relapse prevention, where they focused on management of stress, support of strength and resilience, and relapse prevention, as I mentioned. Later, after his hospitalization for catatonia, he was quite close with his father, who lived with him, noting or focusing a lot on reality testing, assistance in anxiety, and distress management skills within the family individual therapy. The family also engaged in the family group, where they felt grateful to hear from peers and experts, but also to learn about different ways people were approaching communication with their loved one. Initially, the client was actually ambivalent and hesitant to consider work or school, noting a desire to sort out his experience with psychosis and the content of his delusions prior to engaging in work, in part due to fear he wouldn't be able to function until that was clarified. COVID-19 also made things difficult for many of our clients seeking school and work opportunities in the last year and a half. But throughout his C sessions over time, in addition to the assistance with job and vocational goals, they did a lot of work identifying strengths, building confidence, and role playing. He had success in a college course. He developed an entrepreneurial project, engaged in part-time work, and expressed feeling a lot more confidence in future vocational work or vocational and educational goals. As Nami mentioned, peer support has been critical for engagement and empowerment of many of our clients, and that was true of this individual as well. His family was initially curious about what peer support was, and the client was reticent, but after the admission for catatonia, they began meeting regularly. There was an expressed gratefulness for the non-judgmental and non-medicalized space where they could process experiences of psychiatric treatment, including those traumatic experiences. It was also a safe space to start voicing the client's own goals specific to themselves, related to spirituality, dating, as well as school and work. And also a place for the client to practice where they wanted to take their recovery, both in the community and their family, but also with the STEP team itself. So discussions about advanced mental health advanced directives, wellness recovery action plans, as well as determining how frequent the visits with STEP and what team members were most useful to the client. This client was one of the first to share their experience of psychosis in the peer group and was very eager and appreciative of hearing others' experiences of psychosis. And they did a lot of exploration in the community of spiritual and mental health treatment resources. Nami mentioned the importance of having multiple modalities of psychotherapy, and this was a situation that was helpful for the client on that relapse prevention phase. He focused on IRT, where he could talk about coping strategies, psychoeducation. During that time, he also developed a lot of trust within a medical setting and through trauma processing. And then after the development of the catatonic episode, he was able to engage in CBTP and really approach the specific systematized delusions through exploration of belief and development of tools for flexibility. And then with regard to the medication or the medical team, he was very clear initially that he had no interest in, had very little interest in antipsychotics in terms of preventing psychotic symptoms, and was hoping to avoid medications as much as possible. He was also hoping to avoid the medicalized psychiatric prescriber setting as much as possible, and spent the majority of his early engagement with the nurse in the nursing role as a safer place to explore the relationship and previous experiences with medications. Based on some of his experience with delusions, they worked a lot on finding healthy balance in terms of exercise and diet, and some psychoeducation about, or education about sexual health, and generally just being a great support in terms of management of both primary care as well as psychiatric care. This led him to be more comfortable over time. Both the nursing as well as the other roles of the STEP team led him to feel more comfortable returning to the psychiatric prescriber visits, where we were able to safely taper benzodiazepines and discontinue them, as well as find a tolerable and adequate antipsychotic dose. So we wanted to share this vignette to show how access to collaborative, adaptable, and interdisciplinary treatment and coordinated specialty care can reduce barriers and minimize psychotic symptoms while supporting client goals, strengths, and natural supports. Unfortunately, as each speaker has mentioned, it's far too common for clients to suffer negative health outcomes, both due to their experience of psychosis as well as their treatment from psychosis. And to limit these risks and promote well-being, Dr. Chwastiak will now share more about the development of the nursing role on the CSC teams.
Great. Thanks, Christine. So in this next section, I'll describe a pilot study that we've been working on over the past 2 years. And the study aims to support the New Journeys teams in addressing health behaviors and chronic disease risk factors. As Nami and Christine described it, the work has essentially been to develop a role for a nurse on a New Journeys team. So the rationale for this the rationale for the project is that the first episode of psychosis really represents a critical period for intervention to address the substantial health disparities that are experienced by people living with psychosis. It's been well established that compared to their peers, youth and young adults with psychosis have an average life expectancy that's 10 to 15 years shorter. And the majority of this premature mortality will be due to cardiovascular disease. We all know that all cardiovascular disease risk factors are 2 to 3 times more common among people with schizophrenia than the general population. But what Ray showed us is that this elevated risk is evident even early in the course of illness. And the figure on this slide is from baseline Ray's data. And you can see that on program entry, participants had 51% of participants were current smokers, and 48% met criteria for overweight or obesity, and 16% met criteria for prediabetes. And this is despite an average exposure to antipsychotic medication of only 47 days. So how can New Journey teams help mitigate this chronic disease risk? Well, it's about prevention. That's primary prevention of the risk factors and or control of the risk factors to prevent incident diabetes or cardiovascular disease. So when we looked at data from the New Journeys network, we saw similar levels of cardiovascular risk factors as I just presented from Ray's. Specifically, the 2020 evaluation showed that at program entry, a little over 45% of New Journeys clients met criteria for overweight or obesity. But what the evaluation data also revealed was that only 72% of New Journeys participants had BMI data in the data set, that almost 30% did not have data on BMI or physical health outcomes. And it was very difficult for us to do any kind of systematic reporting around physical health outcomes because the Navigate model does not include standardized protocols to track health outcomes. So to address this, we've been working over the past 2 years in a pilot that aims to support the New Journeys teams in the management of chronic disease risk factors. And this work has been funded by generous philanthropic gifts from 2 anonymous donors and some additional funding from Washington State. And we've conducted the pilot in 2 phases. The first phase, as Nami and Christine alluded to, we've collaborated with STEP and some of the other New Journeys teams to adapt an evidence-based integrated care model for the context of coordinated specialty care. And phase 2, which we just launched last fall, is to take the work that we did with the STEP team and implement this role on a New Journeys team in Olympia, and to assess its feasibility, fit, and preliminary impact on processes and outcomes after 6 months. So briefly, the first phase of kind of co-developing this nurse care manager role involved 3 sets of activities. We wanted to learn from the teams about the functions that relate to physical health, health behaviors, and addressing chronic disease risk factors. And the goal of this activity was to identify an evidence-based intervention that we could adapt and implement on the New Journeys teams. So the teams were gathered in July 2019 at a summer retreat, and we had a breakout session for team psychiatrists, which provided an opportunity for us to brainstorm with them about tasks related to physical health and health behaviors. And we asked them what parts are going well, where are your challenges, what are the barriers to completing the tasks that you need to do for this work. And we specifically asked them what help, if any, from within the team or outside the team did you have to complete these tasks? And then this input helped us identify an evidence-based intervention that we spent the next year working with Christine and Anna O'Boyle, the nurse on the STEP team, to build the components of a new role so that it could be implemented at a second site. And then last spring, before we started the implementation pilot, we obtained additional input from New Journeys teams on the work that we completed with STEP. So in the retreat breakout session, prescribers, oops, I just need to go back a slide, Maria. And the prescribers identified several functions that related to management of chronic disease risk factors. And the breakout session helped us identify goals related to each of these functions. Excuse me. In addition to the key clinical functions, there was consensus that the teams also needed systematic approaches to identify patients who were not engaged in care, patients who missed recommended monitoring, or those who were monitored but had evidence of elevated risk that needed further evaluation. We also identified at that point that 3 of the 9 teams, in addition to STEP, had already organized some nursing support for the prescriber to complete these tasks. One used a registered nurse, one an LPN, and one was using an MA. So these functions and goals aligned very closely with a well-established integrated care model that's showed on the next slide, the behavioral health home, and specifically a nurse care manager role within the behavioral health home. I think you're all familiar with this model. It's a community mental health center-based medical home for Medicaid enrollees who have both serious mental illness and at least one chronic condition. It's been around for a while. It was part of the Affordable Care Act, but since that time, over the last decade, it's really been widely disseminated. There have been large-scale implementations in 23 states, and statewide evaluations and one randomized control trial show that this model improves engagement in care and quality of care for chronic conditions. So as I said, over the course of about a year, we met monthly with Anna and Christine to identify the tasks associated with each of these functions and develop tools and templates, workflows, and data tracking tools so that we could manualize the role and prepare to implement it in another New Journeys site. But before we launched the second site, the pilot at the second site, we conducted semi-structured interviews with key informants from all of the New Journeys teams to obtain feedback on the work that we'd done with STEP. So we conducted 7, and this is work that my colleague, Dr. Sunny Chang and Cameron Michaels from our team did last spring. They conducted 17 individual interviews via Zoom with program directors, prescribers, therapists, and some nurses. And really, we're just looking at what are these functions and what was the response to what we'd done with STEP. And a major theme that emerged was just how much the teams valued these functions as critical to their work as New Journeys teams, and that team members were trying to fill these roles, but either did not have the time or the expertise to do them adequately, and that clearly a nurse would be the best staffing to fill this role. So we're currently in phase 2 of the project. We're working with behavioral health resources in Olympia. This site was selected because they just had really enthusiastic leadership buy-in to implementing a nurse on their team. And the intervention is for a dedicated 0.2 FTE nurse to conduct standardized health assessments, meet with clients to support health behaviors and medication management, be primarily responsible for tracking health outcomes over time, and be the care coordinator on the team. And the aims of the study are really to test the feasibility of the role and to track time spent across both billable and non-billable activities, to assess the fit for the context of the New Journeys teams, and then to look at some preliminary impact on processes, mainly monitoring of health outcomes and client level outcomes. So we're planning to complete the pilot and the evaluation by the end of the calendar year. We're currently working with DBHR to try to scale to additional sites over the next fiscal year because it's gone so well at STEP and BHR, and potentially looking to an implementation grant. So I will turn it over to Sarah, but just before I do, want to express deep gratitude to both the STEP team and the BHR team, to Dr. Chang, and to our terrific Spirit Lab team.
Thank you. Well, I'm very excited to talk about a recent clinical innovation related to coordinated specialty care for early psychosis across our state, which is the Central Assessment of Psychosis Service, or CAPS. And I've been the lead of this effort since its conception in 2018 or 19, but it really would not have become a reality without the significant investments from the people who are noted on this slide. So Maria already laid some of the foundation for the challenges that we confront in reducing duration of untreated psychosis. Reducing DUP is considered to be one of the few potentially malleable prognostic factors in a psychotic illness. And the barriers to early detection in the US span structural, cultural, and systemic factors. And then the diagnostic complexities present real challenges to early detection because an emerging psychosis can be quite difficult to tease apart from other more common psychiatric conditions. We know that attenuated psychosis can also be difficult to differentiate from the spectrum of common adolescent developmental changes. And then most people experience a progressive onset, which is far more difficult to detect than an acute onset, which usually we see in the ER. So CAPS is the first statewide centralized assessment program for psychosis and psychosis risk states in the US. And if we can advance to the next slide, thank you. The initial funding permitted for a conceptual development stage, time to work through the UW-Medicine approval process, as well as a one-year startup phase for our first demonstration site, which was the Harborview STEP team. After we established that the service was feasible, acceptable, and that the service was of high value to the program, we were able to secure state funding through the Healthcare Authority, which extends state mental health block grant funding to enable CAPS expansion to all of the CSC programs statewide. And my colleagues and I have detailed the policies, the billing and documentation procedures, tele-evaluation training requirements for CAPS evaluators, and the core assessment battery in a paper here that was recently published in Psychiatric Services. So intuitively, this is a highly scalable, cost-effective model, as well as a model that can help to abbreviate the duration of untreated psychosis, even for individuals who are living in rural and frontier areas, and it can improve the quality of care that they receive. So initially, this service is conceptualized as having two core functions. The first is to remotely administer a comprehensive psychodiagnostic evaluation to a young person to help accurately identify the psychosis earlier in its course. The assessor is based at UW-Medicine. We're actually situated at Harborview, and the individual may be physically located either at their home agency or actually in their own home now, thanks to regulation changes as a result of COVID. So this function has been brought to fruition, and I'll talk about what that process looks like on the next slide. The second core function is extending teleconsultation to professionals. That could be in a school setting, in a pediatrician's office, in a jail. And this is where the professional has concerns that a young person under their care is exhibiting signs, symptoms of an emerging psychosis. So this slide lays out the process for a CAPS evaluation. The process, I won't have time to go through it in detail because I want to make sure we have sufficient time for questions. But there's a few things I will call out. One is that the client has to first establish care at the currently at the New Journey site or STEP team. And that site, the parent agency for that New Journey team, needs to be established as a UW-Medicine site of practice. A site of practice is a contractual arrangement between UW-Medicine and that agency, which extends liability coverage to CAPS evaluators and grants us practice privileges at that agency. So after the client establishes care, the team identifies a need for diagnostic clarification or more refined treatment planning, and will reach out for a referral. The individual is screened by phone with a validated psychosis screener, and we'll begin the testing process. We have multiple testing sessions, record review, collateral interview. That all culminates in a comprehensive testing report, which is provided to the team, and the CAPS evaluator provides feedback, including the diagnostic and social cultural formulations, as well as extensive treatment recommendations to both the family and the clinical team. So we can move on to the next slide. I'll show you here, if we looked at that original slide that Maria showed with all of our New Journeys sites and our Harborview STEP team, you can see in the red boxes the sites that have already been onboarded as a UW-Medicine site of practice and is currently receiving CAPS services. So we'll go ahead and advance to our next steps. So we need to evaluate our program outcomes, and I'm specifically interested in looking at the care plans, looking at cost, and also looking at, do these evaluations affect engagement in New Journey services? This service can help us identify the need for clinical high risk for psychosis services in our state. We currently don't have any specialty care services for this high risk population. And this can give us a better sense of how many folks require these kinds of services. And then with additional funding, I would love to build out the consultation service so that any professional across settings can avail themselves of professional consultation about, is this an emerging psychosis? What should I do with the person under my care? And I hope to work with other UW-Medicine consultation services so that we can create one front door for those who are seeking consultation. So I'll turn things back over to you now, Maria.
All right, thank you. And sorry, you went on to the next slide a little too prematurely here. Thank you everyone for joining us today. And I think given the little bit of time we have, I thought, Joe, if you want to go ahead and go on to the questions, we can do that. I just wanted to point out and keep the slide up related to STEP referrals. If anybody wants to make a referral to the STEP team, as well as more resources, lots of good information about psychosis more generally, as well as early psychosis on the various websites, as well as training opportunities across all three of them, and particularly in the Northwest region related to the Northwest MHTDC. So we'll turn it back to you all related to some questions, which I think are in the box right now.
Yes, thank you. Well, thank you everyone for a team-based presentation and really answering those key objective questions in this new type of presentation for a grand round series. Very informative and motivating. Look at, I mean, thinking about what can be accomplished to provide this high-level subspecialty care to a specific target population with a large group of clinicians, while continuing to evaluate outcomes and effectiveness. A couple of questions came in. One maybe is straightforward. What other diagnoses with psychosis are excluded from the STEP program? Or why are, excuse me, not what, why are other diagnoses with psychosis excluded? Is it related to the CSC intervention being more specific to psychotic disorder, or something else, perhaps?
Yeah, I mean, I can take a hand at that. I mean, yeah, so because of the vulnerability and the need to improve the care of individuals with chronic psychosis, the models were developed specifically for that population, and that's the reason that there are those exclusion criteria. Clearly, individuals with affective psychotic symptoms, substance-induced psychotic symptoms, and other conditions with psychosis are of great need, and certainly an area of future development and research, and hope to develop similar models of care.
A question came in about outcomes related to long-acting injectable antipsychotic medication. I thinking as a clinician, that's got to be a difficult and nuanced decision, and perhaps when diagnosis is unclear or in first episode, does that improve outcomes as the question suggests? Can you comment on that?
Yeah, so definitely long-acting injectable antipsychotics are highly effective and equally effective to oral antipsychotics, sometimes more effective in settings where adherence or taking the medications can be difficult. I think one thing that's surprising potentially to people is that younger individuals are actually much more open to long-acting injectables in our experience in the STEP clinic than previous generations. I think perhaps that has to do with separating long injections from involuntary treatment, as well as the ease with individuals with fewer medications having a lot of interest not in taking a daily medication or having to have the hassle of reminding themselves every day, or even just the experience of recognizing on a daily basis one has to take a medication to treat or prevent symptoms. So we've had several clients find it quite useful, and there is evidence in first episode psychosis that utilizing long-acting injections can improve outcomes.
Thank you. And there is about 2 or 3 minutes. If any other participant has a question, certainly write it in, and we'll try to get to it.
Maybe we could just say, just as we're waiting, you know, just to the original question, the first one about just, you know, excluded diagnoses, and just thinking about, you know, we know there's a lot of unmet need. Like, this is kind of the first step. The federal block grant funding is pretty narrowly defined around first episode non-affective psychosis, and you know, tied to the RAISE study. That's how it was first evaluated, and so then the funding sort of matched that. But also recognizing that, you know, there's a lot of direction that we needed to go in terms of intervening earlier, much of what Sarah described about clinical high risk for psychosis, and helping folks sooner in their illness course before they're even presenting with and actually have an actual psychotic break. And then also thinking about folks who have affective psychosis, you know, what they also have important needs that need to be expanded within the community and you know, across everybody, all across the state. So that's another direction that I think we need to be looking at.
Thank you for that additional information. Curious about 2 points that can maybe contrast 2 points in a minute we have left about a consultation, trying to you know, diagnose first episode psychosis through a consultation versus what sounds like at times can be ongoing assessment over the course of months. Does the consultation guide additional assessment, or is it more definitive? Can you tell us about that?
Yeah, I'd be happy to field that one. So I think it depends on whether the person is able to be referred to a specialty program or whether they need to remain in their primary care setting or, closest mental health clinic, which would not have specialty services. What can be very difficult is where we have somebody who's presenting with an at-risk mental state. We really want to keep a close eye on them. We want to see how symptoms develop. We want to be able to treat any untreated anxiety or depression, irritability, sleep difficulties, so that we can reduce the likelihood that they will transition into a psychotic episode. So we can counsel providers at their home base to be able to, for what to watch for, how to manage behavioral health issues and medical issues. And Lydia and I actually did a presentation on the PAC clinic to primary care providers on how to do that in a primary care setting. But it also speaks to the need for clinical high-risk services so that we can provide appropriate specialty services in an environment that's meant for that population.
Thank you. Due to time, we'll need to stop, though there's many other interesting areas to ask about and discuss. But again, thank you very much today for presenting as a group and for sharing the time across your service to describe what you're accomplishing and what your vision is for next steps. So thank you again, and we'll end grand rounds there for today.
Thank you.